strategy level. So go ahead, Bryan, kick us off.
Okay, great. Hi, everyone. My name is Bryan Garner. I am a Senior Implementation Research Scientist with RTI International. If you'd like to find out more information about that, you can go to rti.org. I'll be talking about the Substance Abuse Treatment to HIV Care Project, or SAT to HIV for short. Again, you can find out more information about that at our website there too. This is a dual randomized type 2 hybrid trial that was designed back in 2013, just shortly after the hybrid trials convention sort of came out with from Jeff Curran and colleagues, and really was focused on testing a strategy called implementation and sustainment facilitation, which for more information you can find at this website. In terms of the context for this project, we were focused on AIDS service organizations across the United States, with their mission being to help address HIV care and improve the HIV care continuum outcomes, for which there were and still are a lot of room for improvements. And in addition to HIV as a public health issue, there's also comorbid substance use and substance use disorders that are particularly prevalent and problematic among that population, and it can really interfere with an organization's ability to address the HIV care continuum and provide services. So as part of the project, we were seeking to simultaneously test strategies for how to help these AIDS service organizations implement an intervention that could help address substance use, but also test the effectiveness of that clinical intervention. So what you see on the screen here is something that might look vaguely familiar to folks. It's somewhat of a hybrid of a combination of on the left, the hybrid design pipeline that Jeff Curran and colleagues have given to us all, sort of combined with the Proctor model. And I use this just since we have like 3 to 5 minutes here to describe this. I'll have to quickly kind of run through this. So this was, again, a dual randomized type 2 hybrid trial in 39 distinct HIV service organizations across the United States. Motivational interviewing was the evidence-based practice, more specifically a one-time 15 to 30-minute motivational interviewing based brief intervention. While this has been shown to be very effective for addressing alcohol use, the evidence is mixed for drug use and hasn't been used much in HIV service organization settings. So while we are big fans of adapting clinical interventions, we have sort of a motto of adapt and test versus adapt and assume. The implementation strategies that we were testing were the Addiction Technology Transfer Center's state-of-the-art strategy that was guided by research and basically includes training, feedback, and ongoing consultation. This is what we believed as sort of the necessary but not sufficient strategy. And so on top of that is the implementation and sustainment facilitation strategy. It's a external facilitation strategy that is delivered virtually. It's only once a month for about 30 to 60 minutes and focused on optimizing the implementation climate and focused on improving implementation effectiveness, which again is one of our main implementation outcomes, which is defined as the consistency and quality with which the implementation is happening. But we expanded the model to also include time to proficiency, which we considered a preparation phase outcome, and level of sustainment, which we considered a sustainment phase outcome. We also included client follow-up and with the days of abstinence from their primary substance being our primary outcome. And the project was also focused on testing moderators first and foremost, as well as some of these same measures as mediators. Here's a flow diagram of it just to also give kind of an overview of how the project went, and then I'll end up the slide here in just a second that shows our main findings. But if you see along the top, you see the EPIS continuum, and during the exploration phase, we worked with, again, 39 organizations. We had 14 from the central part of the United States, 11 from the western part of the United States, and 14 from the eastern part of the United States. We were trying to make this as broad and national as possible. Organizations and their staff and clients were cluster randomized into either just receiving the ATTC strategy or the ATTC plus ISF. A really important point to make, I think, is that the ISF strategy precedes the ATTC strategy in terms of it helps prepare the staff for going to the training, and that's a really important part of our model. We had 78 staff that started the process, and all 78 were successfully trained to demonstrate proficiency. In the implementation phase, we also had 78 staff that were able to progress along. We had 824 clients get randomized either to usual care or usual care plus the brief intervention, and had an 85% follow-up rate with those clients to be able to look at outcomes. And in the sustainment phase, there is always going to be some drop-off, but we were able to do follow-ups with 85% of the staff. In terms of our outcomes, is the last slide, and the main takeaways, this is sort of the whole trial studies condensed into one slide. And what we found essentially was that we know how to train. The HTTC strategy was sufficient for helping staff demonstrate proficiency. We couldn't decrease the time significantly further. So that's great, we know how to train. But what we found was that the ISF strategy significantly improved the extent to which the staff implemented with consistency and quality. And what's really exciting, and I think it's a point that it's some evidence that proves the point Bryan Pittman was making earlier, is that these strategies that are used make a difference. In essence, what we found was that the brief intervention only worked in the organizations that also received the ISF strategy and not in those who only received training. I think this is a super important point that this study demonstrates. And then it also demonstrated, unfortunately, that even the combination of our HTTC strategy plus the ISF strategy was not sufficient for sustainment. Sustainment is a titanium nut that's proven to be very difficult to crack, but we're not giving up. And so we are working to try to build on this as part of the SAT to HIV2 project, where all organizations are getting the ATTC strategy plus the ISF strategy as the control condition, and then half of them have been randomized to also receive pay for performance as a strategy, which as part of some of our prior research we found to be highly effective and cost effective. So to wrap it up, the take homes I have for this completed type 2 hybrid trial are, they are not for the faint of heart, for sure. They are possible, however, with the right infrastructure and team. And I think that they provide a really great return on investment to the funders, because we were able to do so much in this one study to answer a lot of questions. So we're looking forward to seeing how the second trial goes. And thanks so much. Oh, and then lastly, anybody wanting to find out more information about this study, the main findings were published last year in Implementation Research and Practice. You can Google Garner et al. 2020, and I think it'll come up. So thank you very much.
Wonderful. Thank you very much, Dr. Garner. We're all applauding you. We really appreciate your talk. We're going to pivot next. We're going to hold questions for Dr. Garner until the end in the interest of time, keeping us marching along. But Dr. Garner, be thinking with the theme of this session being challenges, opportunities, and recommendations for success for a pitfall or challenge you overcame that we'll be addressing at the end. But we're going to move on now to Dr. Kinsey. We'll let Dr. Kinsey share her slides. Dr. Kinsey comes to us from the Oregon Rural Practice and Oregon Health Sciences University, and really excited to hear her discussing these points for us today, thinking of how practice facilitators bring the support. Thank you, Dr. Kinsey. Go ahead.
Thank you so much. Yes, my name is Erin Kinsey. I'm from the Oregon Rural Practice-Based Research Network at Oregon Health and Science University. And I'll be talking today about how we are combining qualitative and system science approaches to better understand how practice facilitators tailor implementation support to context. So the study is called Antecedent, and it's an implementation science study focused on screening, brief intervention, and referral to treatment, or SBIRT, for unhealthy alcohol use in primary care. And for this study, we have 6 practice facilitators providing support to primary care clinics throughout the state of Oregon. And as part of the study, we're examining how these facilitators tailor their support based on context, intervention, and personal expertise. And one question we're asking in order to understand that tailoring component is, what are the practice facilitators' mental models of practice change? And by mental models here, I mean a set of beliefs and assumptions about how something works. So the method from system science that we're using is called causal loop diagramming, and it's an approach that illustrates causal relationships or hypothesized causal relationships between variables in a system. The main goal with this approach is to identify the relationships and feedback loops that generate the outcomes that we observe. And this diagram here is just an example showing the rationale behind how practice facilitation, shown down here in green, helps support quality improvement capacity for clinics. Now, I don't have time to walk through the whole details here, but I'm just putting this here as an example of the sort of diagram we're talking about. And there's been some research looking at how to systematically generate these diagrams from qualitative text data. And the big picture idea here is if we can develop ways to translate the ideas expressed in an interview, for example, into these diagrams, it opens the door to a new way of communicating and analyzing qualitative data and makes it potentially able to interface more with other sorts of data as well. So this image shows how we went from an interview quotation at the top to a causal loop diagram at the bottom, a section of a diagram. In this quote, a practice facilitator is talking about how when clinicians and clinic staff see patients making positive changes as a result of their improved SBIRT implementation, it can make them more motivated to engage in future improvement efforts. And so this is what we call a reinforcing feedback loop, when actions build on themselves. So we used Atlas TI to assign a code indicating that there's a feedback loop, and then we inserted a comment with some notes about what those relationships might be. After the document's coded, we go through and compile all of these relationships from different quotations into a spreadsheet, upload it to Kumu, which is a web-based visualization platform. And then here at the bottom is the section of the diagram corresponding to this quote. So you can see that feedback loop. So in our study, we're interviewing practice facilitators every 6 months and using this method to generate diagrams for each of those interviews. So we'll be able to look back at how an individual's perspective changed over time and compare between individuals. Here's an example of how 4 practice facilitators had somewhat different perspectives about the role of clinician and staff motivation and buy-in. So the D panel at the bottom right shows the example you just saw in a context. And then there's 3 other mental models as well. And so when comparing these, you can see that some people had a lot more to say about the topic and the variables very more densely related to other variables in their mental model, while a couple people mentioned the idea, but it wasn't as robustly integrated. And so I'll mention here that this approach of using causal loop diagrams to analyze qualitative data, it's kind of uncharted territory. So the existing literature about this approach comes more from a modeling perspective. So in this study, we're kind of learning as we're going along and exploring the ways that this approach might be useful. So the potential strengths of this approach is that it could open doors to new ways of engaging with qualitative data. An angle here is that particularly interesting to me is that the idea of using these diagrams as sort of a common language or framework to represent data from multiple kinds of sources. And we can look at change over time or compare individuals. And this approach can also be used to synthesize the perspectives of individuals in a certain stakeholder group. And when compared to standard group modeling approaches, for example, this method is more flexible because it uses individual interviews. But this approach does require time and expertise. Thank you so much.
Thank you very much, Dr. Kinsey. We'll do a quick question before we move on to our next presenter. Dr. Rabin had put in the chat that this is a really interesting approach to visualize these qualitative data and asked, has this been used in other fields or how did you learn about this approach? Could you speak to that?
Sure. So yeah, this approach has been used within, it's come from the system dynamics field, which is more computation focused, but usually these diagrams are used kind of as a stepping stone to that sort of computational modeling. And there's been some research within that about how to use interview data in particular to inform that modeling, but it's been more within the framework of using that as a means to an end of building a simulation model. And so what's innovative about our study is that we're saying, okay, let's kind of forget the simulation model end of it, and let's see how we can really use this as a framework to communicate this kind of, communicate the relationships expressed in the qualitative interviews and figure out a way to try to use that as a new way of engaging with that information. And so we're hoping that, this is kind of one piece of maybe a larger endeavor where we're hoping that, if once this is refined a bit, we're able to use this as a platform for integrating qualitative results, potentially from stakeholders, with maybe more practice-based data, more quantitative data as well.
Excellent. That was wonderful. Wonderful answer to the question, Dr. Kinsey. So we will transition next to Dr. Pittman. Dr. Pittman is at UCSD and also has appointments in the VA San Diego. And really looking forward to your talk today, Dr. Pittman, helping us think about how QI can bring tech into practice, even in settings like the VA, where that may not be as easy as some other settings. So please go ahead. Let's see, we're not hearing you right now, Dr. Pittman.
Okay, can you hear me now?
Yes, perfect.
All right, great, thanks. Well, I'm very delighted to be here and thanks for having me. My name is James Hout and I'm a social worker at the VA San Diego and at UCSD. And I'm gonna be talking about a quality improvement project that we undertook to essentially facilitate the implementation of a technology into the VA healthcare system. So VHA provides healthcare to over 9 million veterans nationally. Following the wars in Iraq and Afghanistan, we saw an increased numbers of veterans who were coming in to get healthcare. And in order for us to be able to effectively screen and triage those veterans, we came up with developing e-screening. E-screening is a web-based software that allows patients self-report and screening questions, and it interacts directly with the VA medical record system. So we can collect biopsychosocial data, and again, it directly inputs information into the medical record system. So it saves a lot of time for providers. It allows to create a lot of efficiency in the process. Based on the success of our initial pilot, e-screening was named VHA Gold Standard Promising Practice for Diffusion by the VA Undersecretary for Health. But the uptake beyond the original sites was somewhat limited. And so we looked to develop an approach that was a little bit more focused on an active implementation effort. So we turned to quality improvement methods, since this was already a quality improvement project. And we looked at utilizing methodology that's already commonly used in VHA. So each VA healthcare system has a systems redesign program, which uses commonly a process called a Rapid Process Improvement Workshop, or an RPIW. So this comes from Lean Six Sigma methodology, and it's a process in which stakeholders are brought together to systematically analyze a process in a healthcare system, in this case, to look for inefficiency and waste, with the goal of improving the quality and efficiency of the processes and the care that's being provided. So we worked with our local Lean Six Sigma black belt expert, and we modified this RPIW process to focus on integrating e-screening into a clinical program. So we documented each of our modifications, and then we chartered a multidisciplinary group from across the country with multiple VHA representatives, as well as multiple workflows in different clinical settings, so that we could model a process of developing a playbook that would essentially be the blueprint for how clinical teams could be able to integrate e-screening into their workflow. So this included a planning phase where we collected information about a variety of different clinical workflows, the RPIW itself, which was shortened to 3 days to finalize the workflow, develop a target state that included e-screening, and included all of the steps and considerations that we thought as a group were necessary for success. So that included workflow, roles, training, communication, measurement. All of those things were included as part of the final blueprint, which came out of the entire process. And so essentially we used this modified QI approach of RPIW to create a template that then would support other clinical teams using the same approach, the RPIW modified, to be able to integrate e-screening. So our next step was to pilot this process in 2 new e-screening sites. And so we had 2 different sites that had expressed interest in implementing e-screening, and we combined our RPIW blueprint with some facilitation, a site visit, and then we essentially implemented in these 2 sites. For data in this mixed method study, we used qualitative and quantitative data to answer different but related questions. The quantitative survey was a 29-item specific survey that we developed using CIFAR constructs for the most part. And the items were scored on a Likert scale. And then when scoring, when doing the data analysis, we essentially captured the % of respondents who endorsed each category for each of the sites. Throughout the process, we conducted mini interviews where we held 5 open-ended questions during our biweekly telephone facilitation meetings with each of the sites. And we collected data based on the types of diverse contextual factors that would be involved with the adaptations and implementation. Ultimately, the results that we found were that both sites were able to implement e-screening. Site 1, which what notably didn't actually go through the RPIW process. Site 1 did go through the RPIW process, and they had less problems with workflow and staffing issues. They reported less problems. In terms of Site 2, they reported larger leadership, but they had significant problems with workflow and staffing. Ultimately, the process that we used seems to be a potentially effective approach to implementation of a complex program in a healthcare system. We're currently exploring this as part of a multi-step wedge hybrid type 2 trial, and so far have been having a lot of success in doing so. Thank you.
Wonderful. Thank you very much. For those of you who haven't previously given a lightning presentation, it's really hard to get through all these slides in 5 minutes. I appreciate our presenters packing such great information in so quickly. In the interest of time, we'll keep moving along here. So our next presenter will be Dr. Stadnik. Go ahead and load your slides, Dr. Stadnik. Dr. Stadnik is also from the University of California, San Diego, just telling us how much great implementation science is happening there, especially affiliated with their Dissemination Implementation Science Center. So without further ado, I'll pass it to you.
Great, thank you so much. It's a pleasure and an honor to be here presenting about 2 of our COVID-19 community engagement research projects on behalf of my colleagues at UC San Diego, including Dr. Borshika Rabin, my fearless co-lead, our colleagues at the Global Action Research Center, which is a social change organization embedded within San Diego County to facilitate bidirectional knowledge exchange between the university academics and community organizations, and San Ysidro Health Center, which is a federally qualified health center near the US-Mexico border. I'll be sharing about 2 projects, Stop COVID-19 California and Co-Create, both using meaningful community engagement methods to advance COVID-19 testing and vaccine uptake in underserved communities. So we used a variety of community engagement methods for both of these projects. Both were anchored within community advisory boards, and I'll tell you a little bit more about those, the composition of those advisory boards. We completed a theory of change in both projects that have guided our subsequent work, and we're moving into an appreciative inquiry stage, which I was delighted to see is one of the community engagement methods on the DICE methods website that I checked out this morning. In addition to our advisory board, we've also been pursuing a mixed methods needs assessment to really understand preferences, values, and attitudes about COVID-19 testing and preventive care in different communities. As you can see, for both our survey and our qualitative data collection, we've been very intentional about including a number of languages that represent our diverse communities in San Diego, including a large immigrant and refugee population. So going forward, I'll tell you a little bit more about our community advisory board meetings and groups. So through our Global Action Research Center partners, we have identified and convened 2 community advisory boards. They include 33 members across both groups, including 2 policy partners at the district level to help with identifying what kind of from local policy can we infuse into our programming. And we've completed a total of 15 meetings over the past about 6 months, all virtual. So we've used a number of different tech platforms, of course, Zoom, which we all know and maybe have some love-hate feelings with, some breakout rooms. We've also used Miro boards, which are essentially like a virtual sticky note platform. We can create ideas and then sort them and categorize them. And I'll show you what that looks like. And then fundamental to this, we've included live interpretation. We've had the great honor of having both Spanish-speaking community members and English-speaking members. So to foster that kind of meaningful participation from all members, we've had live interpretation during those meetings. So a few lessons learned that I'd like to share. Number one, we've learned the importance of translating all written materials so everyone can kind of meaningfully understand and engage in the conversation. Speaking slowly, taking breaks for interpretation. Technology assistance has been critical in terms of both providing the hardware, laptops, hotspots, and then also the ongoing assistance for some of our community members who have lower technology kind of understanding and literacy. We've been meeting almost monthly or sometimes twice monthly in the late afternoon, early evening times, which has worked well so people can engage, after work. We've also made sure to compensate all of our community advisory board members. They're taking their time to contribute their knowledge and expertise, and we want to make sure that that is acknowledged appropriately. We've used scribes and facilitators in each of our breakout rooms to help foster and kind of keep conversation on track. And we've ended each of the meetings with a reflection from each of the CAB members, which has been really insightful and informative. So our methods, we've been engaging in the theory of change process over the past 6 months or so with our advisory boards. And many of you might be familiar with the theory of change. Lovingly, it's referred to as a logic model on steroids. It essentially allows multiple stakeholders to engage in a process of elucidating a description and an illustration of how and why a desired change for us, this was equitable COVID-19 testing and vaccination, how that desired change is expected to happen in a particular context. And so over the next, over about 6 sessions, we went from the generic theory of change into what you see, that color-coded theory of change, which allowed us to understand what are the necessary conditions for testing and vaccination equity, actions to create those conditions, and a blueprint for assessing efficacy. So each of the sessions was guided by a similar format. So there was a focus question posed, ideas were generated. We were we broke out into separate rooms to discuss those ideas. We came back as a full group to sort the ideas into different categories, and we named the categories, finally ranking them in order of importance. And so what you see here are some of the Miro boards where we have sorted our ideas into different categories and then we named them. So for example, one of the necessary conditions for equity, COVID-19 testing, equity and vaccination was access to trusted, truthful information from government sources. So we went through that to elucidate the contributing factors, necessary conditions, actions, and indicators of success. Our next steps are now to engage our advisory board in an appreciative inquiry process where we evaluate the implementation of the actions that we set forth. So with that, I want to say thank you. Both these projects took a whole village of amazing and creative people, and I wanted to acknowledge them. So thank you for your time.
Thank you very much, Dr. Stadnik. Excellent presentation. We'll be moving on now to our next and final speaker in the session, and then we'll field some question and answer. Please feel free to put questions in the chat. This is Dr. Hout from University of Ottawa, and I'll let her take it from here in the interest of time.
Thanks so much. So as mentioned, my name is Shelley Hout. I'm a postdoctoral fellow at the University of Ottawa here in Canada. And today I'll be speaking about the prevalence and factors associated with patient-reported outcomes in pragmatic RCTs. So to provide a brief background, pragmatic RCTs, as we know, are intended to guide clinical decision-making and studying interventions and patient-important outcomes in usual care settings. And at this stage in the field of patient-oriented research, we also like to see patients being engaged and involved throughout the research process. Now, patient-reported outcomes, or PROs, are subjective measures of health that come directly from patients without interpretation from anyone else. And PROs are considered patient-centered and well-suited to pragmatic trials. However, their use and reporting in pragmatic trials has not been described. So the objectives of this study were to determine the prevalence and types of PROs, as well as factors associated with the use of PROs among health-focused pragmatic RCTs. So in terms of methods, an electronic search filter was developed and applied to Medline to identify primary reports of health-focused pragmatic RCTs published between 2014 and 2019, registered at clinicaltrials.gov. In terms of data extraction, trial descriptors were downloaded from clinicaltrials.gov as well as extracted manually. And for analysis, descriptive statistics were used to summarize trial characteristics, and various tests of association were used to compare characteristics of trials with and without PROs as primary or co-primary outcomes. So moving on to results, 415 trials met the inclusion criteria. So among these 415 trials, 35% use PROs as primary or co-primary outcomes, 22% use PROs as secondary outcomes only, and 43% did not use PROs at all. We also wanted to understand if patients were engaged in the research process. And so we've only found that in 9% of all 415 trials were patients reported to be engaged, whereas in the remainder of the trials, it was either unclear or not reported. And finally, in terms of types of PROs used, among both primary and co-primary, as well as secondary PROs, the most common types of PROs used tended to be symptoms, health behaviors, and quality of life or health-related quality of life. Now, for factors associated with the use of PROs as primary and co-primary outcomes, we found that there was a higher prevalence of use of PROs among trials conducted in Europe, those which had a primary purpose of treatment, those which tested dietary or behavioral interventions, and those which were individually versus cluster randomized. We also found that there was a lower prevalence of use of PROs among trials published in higher impact journals, those conducted in low or middle income countries, those which included exclusively pediatric or older adult populations, and those which were industry funded. And finally, there was no association between the use of PROs and patient and stakeholder engagement, clinical versus non-clinical setting, year of publication, and government, university, or foundation funding. Now, finally, for discussion and implications, we found that PROs broadly were infrequently used in pragmatic trials, and patient and stakeholder engagement was rare. Trials which were individually randomized, those conducted in Europe, and those which tested dietary or behavioral interventions tended to use PROs more often, whereas trials published in higher impact journals or funded by industry were less likely to use PROs. And so moving forward, research funding bodies, institutions, and scientific journals can support the use of PROs and patient engagement in pragmatic trials by establishing policies, providing method support, and creating incentives for researchers. Now, I'd like to acknowledge my study team as well as the funding sources for this study, and I thank you for listening.
Wonderful presentation, Dr. Hout. Thank you so much. So now I'd like all of our panelists to unmute and go on video so that we can have a panel discussion. As promised, I'm going to kick us off and I'm going to ask each of you in turn to address in 30 to 60 seconds. Difficult. So you already did a lightning presentation. Now I need a lightning Q&A, but I'd like you to tell me about a challenge that you had to address and how you overcame it, or a surprise from the work. And we're going to go back in order as we began our presentation. So Dr. Garner, first question to you.
Okay, thanks, Amy. I think with our dual randomized hybrid trial, the biggest challenge that we faced was balancing the implementation aim, which I think precedes the effectiveness aim. You can't test the effectiveness without implementing, and implementation is hard. And so the idea of being like, what's the more important aim? Are we trying to see if they can implement and then how well and our strategies work? But if they don't implement well enough, there's not enough clients to test the effectiveness with. And so balancing those aims all along the 5 years was really hard. And we ultimately decided that our implementation aim was the more significant and unique aim, given the state of the field, as opposed to the other. So when it came to the point where there was a tension between the two, we erred on the side of focusing on answering the implementation aim and not. And so in some ways what happened was that our recruitment was not what we had budgeted for and expected, but that's because we were trying to not interfere any more than what our implementation strategies that we were testing were doing. So I would say that was our biggest challenge in it, but
that's very interesting. Just really quickly, when you say your recruitment wasn't what you expected, did you end up over recruiting or under recruiting?
Under recruiting, and the reason is right, if you're going to test when you're powering up for a multi-site effectiveness trial, in the ideal world you would have just lots of people, and that's how efficacy trials work. And the PI and the team will get involved and make sure it happens. In a dual randomized hybrid trial, you're trying to see can they do this? Can they implement? And it's hard. And so they undershot. Now we still had over 800 clients, so we were able to test it, but it's a challenge.
It's a really good point. It highlights those tensions of a pragmatic trial in terms of some of those pieces with power. Dr. Kinsey, same question to you next, a challenge or a surprise that you had to address and overcome.
Sure. Well, because our study was looking at how practice facilitators tailor their implementation support and their mental models around practice change, we had to not just document in our study what happened and when, but more around people's thought processes and really trying to get at why they made certain implementation choices. And so we needed to sort of get a more robust set of information in order to generate those diagrams. So we ended up relying on sort of database like field notes, so they take field notes after encounters, but we also are doing monthly group periodic reflections where we get some dialogue, they can compare notes. And then I've also done a series of individual interviews to kind of really probe and get at what their thinking is with these individual facilitators. So having those different sources of information was really important.
That makes a lot of sense. Thank you so much, and appreciate all of you giving succinct answers to a tough question like what was a huge challenge you overcame. So Dr. Pittman?
Yeah, so for our project, since we were doing a quality improvement project, I think one of the biggest challenges was that we didn't set out to do it in a way that was the same way we would if it was a scientific project, if it was implementation science versus quality improvement. And so capturing a lot of the information about what was happening retrospectively, as we decided that it potentially be a useful project to share, was a pretty big challenge. So I think one of the benefits of QI is that it's kind of embedded and we can go and do it. But one of the challenges was not having the mindset to be capturing as much information about the process as we might if it was research.
That makes a lot of sense. And of course, it's still research, but I know exactly what you mean, the different standards that you had to apply there. So Dr. Stadnik, a brief response to you on a challenge or surprise you had to address?
Absolutely. I think for us, some of the challenges have come as it relates to how can we best and most appropriately respond to community needs, especially of our advisory board. They're a very diverse group of community residents, patient advocates, providers, policy partners. So two examples in particular. One has been related to our efforts to include as many different languages as possible in our data collection and in our advisory board meeting and just engagement processes. We've received so much just helpful and important feedback that English and Spanish are a good start, but if you're living in a very culturally and ethnically diverse area, you need to do as much as you can to reach and engage people from all different communities who have different experiences. Another kind of challenge and issue that we came up against was
Nicole, do you mind letting me go to our next person before you share that next challenge? Would that be okay? Just in the interest of time?
Absolutely. I get so excited about this. Thank you.
There's a lot of excitement, a lot we could say, and yet I am forced to be the bad cop timekeeper.
Absolutely. Go on. Thanks so much.
Dr. Vanderhout, and a response from you.
Thanks, and sorry to cut you off. I do want to hear that other challenge, Dr. Stadnik. I would say one of our main challenges was just really getting down to the reporting. So just due to resource constraints, we weren't able to go back and look in either secondary publications or supplements, as well as protocols for our study. We just limited it to primary reports, and just because you can understand or you can imagine how that might kind of open many cans of worms to kind of dig for all of that data. And so PROs, when they're used as secondary outcomes, especially if trialists don't find any significant or evidence of a relationship or significant data, they often don't report the outcomes, and they just kind of leave them out of the primary reports, and they fall to the wayside. And of course, this is an important thing to still capture, even if that evidence doesn't kind of come up with anything truly remarkable in their eyes. I think it's still really important to understand, even if there wasn't any effect or findings that they found to be notable. And so we just found anecdotally, we did see sometimes where we had observed PROs to be included in protocols, but then they don't show up in the final report. And that really makes a limitation in the research that we were doing.
Great comments there. I really appreciate you bringing that to light. Dr. Pittman, I'm going to pass the baton to you here for our last 3 minutes of the session, and then I'll give some housekeeping comments at the end too about what's coming up. But please take us away, Dr. Pittman.
Sure. So I think I'm going to start from the inside out and ask, for the most part, yes, no questions. So James, is it possible, or would there be differences if you were to use this approach for other sites within the VA based on the initial VA experience versus other sites, for example, Kaiser? And could it be streamlined for VA and made more efficient than the full approach that I assume you'd use in Kaiser?
Yes, I think it could be streamlined for the VA, particularly because they have the infrastructure in place to do these RPIWs as a standard of practice.
So Nicole, again, a quick question that I think may be yes, no, and that is, the full version of recommendations for stakeholder engagement has stakeholders engage in all processes in the research, or all steps in the research process, all phases. Question is whether you could use this approach for other phases, planning and conducting dissemination, data analysis, interpretation.
Yes, absolutely. And that's in part what we're doing. We have Monday 8 a.m. calls actually with our community stakeholders to do this very process, kind of the whole from start to dissemination. So yes.
Quick question again for Aaron, and that is, so one version of recommendations for studying these kinds of interventions is that we develop an a priori causal model, and then we use both qualitative and quantitative data to adapt and refine that model. And in some cases, the output of the study is the better model rather than effect size estimates. Is the approach that you've described, which I agree with some of the comments, is highly innovative and effective, can that be used to iterate and to incorporate quantitative results?
Yeah, absolutely. So there is some precedent within the program evaluation realm to use this sort of approach as a way of communicating a theory of change. And so a sort of an initial hypothesis of how an intervention is supposed to work. And so, yeah, I see the research that I presented today as part of a larger process of iteration between what we think we're going to encounter and what we find that we encounter, for sure.
So Amy, I have two more, or we can go into the next step.
You get whatever you want with the last minute of our time, Dr. Pittman.
Okay, so Shelley, quick question. So obviously good news that we see increasing use of PROs, bad news that there's not other evidence of, so I guess my question is for your policy practice recommendations, why do you think that we've seen change in some aspects of engagement and patient-centeredness, but not others?
Yeah, that's a great question. I'd like to think that maybe there is an increase in patient engagement and stakeholder engagement in the design of trials. And so hopefully that has really kind of taken over and lent itself to including PROs in trials and will contribute to a further increase in their inclusion in future trials. But as long as they are in fact patient-centered and patients are advocating, then I would think that would be the trend that we'll see.
Okay, and Bryan, quickly, you in your conceptual model, listed moderators of the implementation process. My question is whether you also examined mediators and moderators of the clinical intervention, the ATTC strategy.
We did, and so the moderators were tested as part of our a priori hypotheses, and none of them were significant, which is actually probably a good thing. There wasn't differences based on readiness or any of those things. And as far as mediators, they came close, but we didn't quite get statistical significance. So we're still kind of working on that.
Okay, thank you to all of you. Very nice talks. And Amy, thank you for the opportunity.
Oh, thank you for co-facilitating with me. And we are getting the lunch bell for those of you who this is lunch, or a break bell otherwise. So this is my housekeeping comments to say what's next is there's a break where you can join in the hallway conversation portion. Dr. Kwan will be there. I put this in the chat as well. A primer on pragmatic trials and introductory talk will be at 12:30 Mountain Time if you're interested in that. Otherwise, at 1 p.m. Mountain Time, the concurrent sessions resume in 2 tracks, either the implementation science track or the data science track. And thanks everyone. It's been a wonderful morning for these presenters today. I think you can tell why they were named as the best of COPRHCon. Obviously, a lot of great material presented.
Thanks, Amy, Bryan, and everyone else.
Thank you.
Thank you so much.
Thank you.
Thanks, everyone.